You are bleeding. Not metaphorically, not as a thought experiment. A blade has opened your forearm to the bone and the blood is moving faster than you expected, darker than you expected. And the man crouching over you has no refrigerated plasma, no compression bandage rated to military specification, no number to call. He has linen. He has vinegar. He has his hands. And he has seen this before. What he does in the next 4 minutes is the only thing that matters. Not his theory of the body. Not the gods he consulted that morning. Not the humoral framework he will happily explain to you later if you survive to hear it. The blood is the fact. Everything else is commentary. And this is where ancient medicine earns its strangest kind of respect, not in the parts where it got things right for the wrong reasons, but in the parts where it got things right because the body in front of it gave it no other choice. Hemorrhage does not wait for doctrine. A person losing blood from a significant wound has minutes before the body begins shutting down its own periphery to protect the core, before confusion sets in, before the pressure drops past the point where the brain can keep its story straight. Ancient practitioners did not know the fluid mechanics of circulatory collapse in any formal sense, but they knew the outcome. They had watched it. A man who bled fast died fast. A man who stopped bleeding had a chance. That observation, repeated across every culture that left any record at all, is the foundation everything else was built on. The theory came later. The pressure came first. The Edwin Smith Papyrus, copied around 1600 BCE, but likely reflecting surgical knowledge centuries older, describes the treatment of wounds with a directness that still reads as clinical. You press, you bind, you hold. Specific cases in the text describe packing fresh meat against a wound on the first day, a detail that sounds like ritual but carries a mechanical logic. Dense animal tissue packed against an open vessel applies even, sustained compression while conforming to the shape of the wound. Linen bandages appear throughout, wound tight, layered, held in place. Elevation of a bleeding limb appears implicitly in how certain injuries are described and managed. These are not lucky guesses. They are the result of watching what slows the flow and doing that thing again the next time. Hippocratic texts written in the 5th and 4th centuries BCE extend this into something closer to system. The corpus describes bandaging technique with enough specificity that modern historians have reconstructed the wraps. It instructs on positioning. It notes that certain wounds bleed more from certain angles, a functional observation of hydrostatic pressure even without the vocabulary for it. Celsus, writing in the 1st century CE, goes further. His De Medicina describes the use of lint packed into a wound, soaked in vinegar or wine, bound and held as a first response to severe bleeding. Not because anyone had a germ theory, because the astringent sting of the acid caused the tissue to contract and the vessel walls to narrow. The mechanism was invisible to them. The result was not. The materials these practitioners reached for were not arbitrary. Vinegar is acetic acid, weak but real, and its effect on exposed tissue is vasoconstriction. Wine carries both alcohol and organic acids that act similarly at the wound surface. Honey is hyperosmotic, meaning it draws fluid toward itself and away from the wound bed, creating a local environment hostile to the softening of a clot. Linen, torn into strips and packed tightly, provides mechanical tamponade. The cobweb, which appears in Dioscorides and was still being prescribed in European surgery well into the medieval period, is a stranger story. Spider silk is hydrophobic and sticky, and packed into a small wound it may have helped trap platelets at the surface and hold early clot structure in place. Whether that effect was reliable or consistent is a harder question, but the people using it had watched it work often enough that they kept recommending it. That pattern, see it work, remember it, repeat it, is a form of empirical medicine even without the formal scaffolding. Mineral powders enter the record too. Alum, which is potassium aluminium sulfate, was used as a styptic across Greek, Roman, and Egyptian sources. It is still in styptic pencils sold at pharmacies today. Its mechanism is real. It precipitates proteins at the wound surface, forming a kind of seal over small vessels. The ancients did not know that. They knew the bleeding slowed. That was enough. But sometimes none of it was enough. A deep wound in the thigh or the neck or the inner arm where the vessels run close to the surface and wide, a wound like that does not respond to vinegar-soaked linen held in place by a frightened hand. The blood keeps coming. It comes through the pack. It comes through the bandage. It comes in a pulse that matches the heartbeat, which the practitioners of this era understood as significant even if they debated what the heart actually did. And at that point, the logic of the situation becomes brutal and simple. The vessel is open. The vessel must be closed, not persuaded, not soaked. Closed. That is where the approach shifted from material pressed against tissue to instruments pressed against something deeper, to fire, to metal, to the tying of the thing itself. That transition was not a departure from the practical reasoning that started with pressure and linen and vinegar. It was the same reasoning, followed forward to the place it had to go. The iron is already in the fire. It has been there long enough that the tip is the color of the sun at its edge, orange fading toward white, and the man holding it is not hesitating. He has done this before. He will press it against the open vessel in your leg, and the vessel will close and the bleeding will stop, and you will scream, and then, if you do not die of the shock or the infection or the fever that follows, you will live. That is the arithmetic. It is not kind. It is not meant to be kind. It is meant to keep the blood inside you, which is the only arithmetic that matters when the alternative is watching it leave. Cauterization appears in medical records old enough that its origin is lost. The Edwin Smith Papyrus references fire in the treatment of wounds. The Hippocratic Corpus discusses it with something close to clinical precision. Which wounds, which vessels, how deep, how long. By the time Celsus is writing in the 1st century CE, he treats it as a standard option in a hierarchy of decisions, something you reach for when the vessel will not close by other means. The logic was not mysterious. Heat denatures protein. It collapses the vessel wall. It seals the lumen shut the way a melted straw seals itself. No one in the ancient world would have described it that way, but they were watching the same result that description produces. The blood stops, the tissue chars. The wound, if it does not become infected in the days that follow, contracts toward closure. The limit was obvious and they knew it. Cautery applied too broadly destroys tissue that was not the problem. It opens the door to necrosis, to the slow death of surrounding flesh, to a wound that is closed but rotting. Every practitioner who used it regularly enough to write about it understood that fire was a last instrument, not a first one. The decision to reach for it was already an admission that everything before it had failed. And that is where a second approach enters the record. One less dramatic but more precise, and where the history of hemorrhage control becomes something stranger than a catalogue of pain. Vessel ligature, the tying of a bleeding vessel with thread or cord, appears in the ancient sources, but its systematic use belongs to a specific name and a specific moment. Albucasis, the Andalusian physician writing in the 11th century, describes in his surgical compendium Al-Tasrif the isolation and binding of a vessel with thread as a deliberate technique, not a desperate improvisation. He describes the instruments. He describes the sequence. His text became a foundation of European surgical training for centuries. The idea that ancient and medieval practitioners were simply burning and hoping is a myth his pages make very difficult to sustain. Then Ambroise Paré, the 16th century French military surgeon who had watched more battlefield amputations than most men see wounds in a lifetime, made the break that belongs in the history. Before him, amputation stumps were cauterized with boiling oil poured onto the severed tissue, the vessel closed by mass thermal destruction. Paré, partly by accident and partly by observation, found that stumps dressed without the oil did better. He began using ligatures on individual vessels instead of cauterizing the stump whole. His own account of the transition is honest in the way that good science is honest. He saw the outcome. He changed the method. He did not have a theory that fully explained why it worked. He had results and he followed them. What is easy to miss from this distance is how rational the brutal framework actually was inside its own constraints. Ancient and medieval practitioners had no way to replace blood. None. The concept of transfusion does not appear as a practical reality until the 17th century and does not become reliably safe until the 20th. There was no buying time with a fluid replacement while you decided what to do next. The bleeding had to stop on its own terms or the patient was gone. That single fact makes every harsh instrument in the record legible. Cautery, ligature, amputation of a limb that would not stop hemorrhaging, all of it was shaped by the same wall. You cannot replace what leaves, so you stop it from leaving at any cost the patient can survive. The brutality was not indifference. It was arithmetic without options. Humoral theory ran alongside all of this and sometimes interfered with it. The belief that blood was one of 4 fundamental fluids, that excess of it caused certain conditions, that bleeding from a wound needed to be balanced against the body's overall state, led to decisions that looked strange and sometimes made things worse. But the practitioners holding those beliefs were not fools. They were working inside a system that had no microscope, no hemoglobin count, no measure of blood volume, no way to see what was happening at the vessel wall. They had observation, inference, and a framework that had been refined by generations of people watching bodies respond to things done to them. The framework was wrong in deep ways. The observation was often right. Those two things coexisted in the same hands. The traces left in later medicine are real. Ligature survived into modern surgery, refined but recognizable. Pressure and elevation and wound packing are still first response. Alum is still in your pharmacy. The principle that a vessel must be mechanically closed when it will not close on its own runs from the bronze cautery iron to the surgical clip placed laparoscopically today. The instrument changed, the conclusion did not. What the ancient practitioner with fire and thread understood, underneath the theory he would have happily given you, underneath the doctrine and the humoral language was something simple and permanent. The body wants to live. It will close small wounds on its own, given half a chance. The job was to give it that chance by handling the ones it could not close alone, by any means that worked, because no means that worked was cruel if the alternative was watching the blood keep moving. They were not monsters. They were people with iron and thread and a body in front of them, working the only problem that mattered. If this history surprises you, it should, because the hands that first tied a bleeding vessel off were following the same logic your surgeons follow now. They just had less to work with, and they still found a way.